I'm Rose Kim, the Assistant Dean for Faculty Affairs. Welcome to our final Medical Education Grand Rounds lecture for this academic year. I'm happy to introduce Dr. Pamela Williams. Dr. Williams is the Associate Dean for Student Affairs and an Assistant Professor of Family Medicine at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. She graduated with a BA in chemistry from Franklin and Marshall College, then earned her MD degree from the University of Pennsylvania School of Medicine on an Air Force Health Professions Scholarship. Upon graduation from medical school, Dr. Williams entered active duty service and completed her residency in family medicine at the David Grant U.S. Air Force Medical Center at Travis Air Force Base. Dr. Williams is board certified in family medicine and is a diplomat of the American Board of Family Medicine. She is also a fellow of the American Academy of Family Physicians, and she maintains an active clinical practice and has produced many publications and presentations reflecting her breadth of interests, including women's health and medical education. Dr. Williams has worked for 20 years across the medical education continuum. Prior to her current position, Dr. Williams served as the Assistant Dean for Clinical Sciences at USUHS. She has previously served as the Director of Medical Education and DIO at the 99th Medical Group, Mike O'Callahan Military Medical Center at the Nellis Air Force Base, where she was responsible for the operations of graduate medical education, including support for the training of medical and dental residents annually in 5 training programs. Dr. Williams was the program director of the David Grant U.S. Air Force Medical Center Family Medicine Residency Program, 60th Medical Group, Travis Air Force Base from 2010 to 2014. Her former faculty positions also include core faculty in 2 family medicine residency programs, as well as in the Department of Family Medicine at USUHS, where she served as the director of the family medicine clerkship from 2004 to 2009. We're pleased to have Dr. Williams speak to us today. Her presentation is titled, Optimizing the Learning Climate. Please join me in welcoming Dr. Williams to the podium.
Well, thank you for that introduction, and I really treasure the opportunity to come and speak with all of you on what I think is a very important topic. As you heard, my career has taken me across the curriculum, spanning the undergraduate to graduate medical education environments in leadership roles. And in doing all of that, I really appreciate the fact that our learning climate really is a space for learning, it's a space for understanding, and it's a space for our learners to experiment. And it is really enhanced or inhibited by the role of the faculty and all individuals who work in that space. We know that a supportive climate of education has many benefits for those individuals working within it, both benefits for the students and residents as well as for the educators. Our learners who work within a supportive environment are better able to perform on their in-training exams and have better board certification score outcomes. They report improved quality of life compared to peers who don't. There are lower rates of burnout, a lower likelihood of ultimately leaving the practice. So yes, the impact of a learning climate impacts our learners not only during their time in training, but after they leave our training. There are patient safety benefits to an optimized learning climate, including having trainees who are more likely to call an on-call physician that they're working under if they have a concern. And as I mentioned, the benefit is not only for our learners, but our faculty benefit, with one study showing that faculty who work within optimized learning environments have better evaluations on their teaching performance. So it's really beneficial to all parties in this room for us to really think about ways that we might work together to optimize the learning climate for all individuals. I am an active duty member of our armed forces, and so I need to let you know that everything I'm going to talk about today are my own opinions, and they do not represent my medical school or the Department of Defense, and I don't have any disclosures for you today. You know, our students expect and they desire to work in an environment we'll work through our slide sets, that really is beneficial. And we are going to talk today about that learning climate in medical education. We're going to talk about the impact that a key element of the learning climate the hidden curriculum has on our educators. I'm going to tackle the topic of microaggressions. In our work in our institution, we're finding that microaggressions seem to be a key factor that seems to be impairing elements of our learning climate, and there are some studies around the country demonstrating that there is much of this impacting our students. And I think this is an area that we're finding addressing may be an avenue that we can lead to culture change that can improve our learning climate. And ultimately, with respect to that, I would like for you to leave here with some practical and pragmatic ways to think about responding to microaggressions that you may have in your learning environment as a strategy that may help you to think about ways that you might work on improving your learning climate as well. So what is the learning climate? The learning climate, when we attempt to define it, has been described in many different ways in the research that is done in this domain. A nice general way of thinking about it is to consider it the prevailing mood, the attitudes, the standards, the tone of your clinical or classroom environment. It is indeed one that is complex. It has many dimensions, both formal and informal. It's been called the soul and spirit of our academic environment. Another person talked about it as being a complex, chaotic kind of situation with countless components, a myriad of dynamics, interactions and inputs and processes, inevitable conflicts, and it's constantly in a state of flux. Wow, that's a lot to unpack. What can we do? How can we think about it? But the studies have demonstrated there are clear differences in learning climates across medical schools and even across departments within medical schools that suggest that there are modifiable ways that we can address and improve that climate for our learners. So if it's so complex, can we break it down into pieces, and can we take apart those pieces and tackle different elements to help learning our climate? Well, there may be some ways that we can work in that direction. The Royal College of Physicians and Surgeons from Canada pulled together a consensus conference in 2018, bringing global partners together to try and break apart the different elements of the learning climate. And they came up with this concept of 6 different, what they termed avenues, or 6 different lenses through which we might be able to start to think about this climate of learning. And you can see as you go around the clinical learning environment and the different elements, you see topics of diversity and inclusion, psychological, which includes psychological safety for our learners, the educational elements, our formal and our informal curriculum, our modes of assessment, social and cultural elements, basic architect, that's a nice, I thought I included that was from their graphics, a nice little typo, sees what goes into our journals today. And then the digital, the social media element. But in all of this, when we talk about diversity, inclusion, psychological and social and cultural, all of those hit elements of safety, elements of hidden culture, and some strategic areas where we need to think about ways that we can focus and help our learners to feel comfortable, safe, and able to be vulnerable as they explore, educate, and learn in these environments. So do we really need to care about all of this? Does it really matter? Well, our accreditation bodies really do emphasize the importance of us paying attention to this and expect it of us. The LCME Standard number 3, which I'm projecting for you here on the screen, has been an area of emphasis since about 2008. So it mandates that we attend to this issue and ensure that our program of learning is professional, respectful, and intellectually stimulating for our learners. And we're trying to help our learners really obtain those future competencies that we have that we want to impart upon them. This is not, as you all know, just focused in on the undergraduate medical education environment, but has been a key part of the accreditation elements and the core program requirements on our ACGME accreditation side. And you'll see that we have the charge to ensure that we, as faculty, are modeling the important humanistic environment that supports the professional development of our learners, and really have to have a commitment to the overall well-being. Beyond accreditation, why else should we care? Are there any harms or challenges that occur as the result of a more negative learning climate? Well, we've identified, the studies have shown that individuals who are within climates that have more negative elements, that have higher risks for our learners to have experienced mistreatment. These individuals in these environments, so these learners, both residents and medical students, have lower levels of confidence, decreased work satisfaction, higher rates of depression, more concerns and challenges with substance abuse, higher rates of burnout. And what we're very concerned about in medical students is an erosion of empathy. So I think these are all behaviors, these are all challenges that we might agree upon as being things that we would prefer to avoid being the impact of our educational environment. So I think it's time for us then to start to delve into a piece of our curriculum that may be perpetuating and these behaviors and influencing the distress that our learners may be experiencing, and that is the one of the hidden curriculum in medical education. So what is it? The hidden curriculum is felt to be things that we teach without purposefully teaching them. It's not what we actively teach in our curriculum, it is what we teach sometimes with simply our actions. And they are embedded, these hidden curriculum are embedded deeply into the organizational structure and the culture. And though sometimes they are things that we intend to teach, they are oftentimes things that we actually weren't intending to teach through our actions and our behaviors, or our inactions and behaviors. What types of things am I talking about? Well, there was a nice study, a thematic review of the hidden curriculum in medical student narratives from a well-known medical school that asked students to reflect upon what they saw as after describing to them what the hidden curriculum is, what they saw in their third-year experiences, their third-year clerkship experiences. And the themes that came out are listed for you here, with over half of the students speaking to the challenges that they experience with power and hierarchy and unintended messages that may have occurred, but also they're beginning to understand how power and hierarchy really work and influence education, influence healthcare. A third of them talked about the difficulties they saw with the dehumanization of individuals that were under their care, the challenges they felt with being under the microscope and the hidden assessment that occurs throughout their medical education, the limits that they felt that they were placed upon them on their ability to express their emotion or experience their emotion or understand the emotions that they would experience as they took care of the sick, the healthy, as they worked within their team dynamics, learning the limits of medicine. So these are important, and it's important to think about these because when students experience the hidden curriculum, when learners have this and they don't have an opportunity to sort of reflect upon it or have role models that are showing them positive ways that these different themes are playing out in medicine. The impact is one of confusion, moral distress, and what can be termed cognitive dissonance. And so it creates problems for our learners that may be eroding their sense of self-confidence and leading to this distress and burnout. And so there's been some conversations, and the American College of Physicians has challenged the medical education community to think about, is there a way that we can flip that hidden curriculum from being one that is more likely to cause distress and degrade our confidence in our learners to being one that is more positive? To think about, is there a way that we can take the actions that might previously have been not spoken about or considered or explicitly been part of our dialogue, and can we be more active in teaching our learners about these qualities, these behaviors, by being more proactive in our stance towards modeling empathy with our patients, by taking the time to pause with our learners about what they are seeing in their educational environment through activities such as reflection, to talk about not only the positive things that they are facing within the academic environment, but when there are negative or uncomfortable situations that they observe, can we take the time to pause and have conversations around those observations? The importance of promoting clinician wellness, both within our individuals and our institutions. And those may be ways to align the hidden with our more formal together. Another stance that they take is the importance that we must be much more aggressive about fostering a learning environment that pushes respect and integrity and honesty in all of our elements. And an area that I want to focus in on as we go through and continue down the pathway of my conversation with this morning is, what can we do to empower individuals who are working within our environment to speak up, to build a stronger culture of respect, because we have learners who are feeling intense pressure to know their place in medicine and to accept the authority of those around them. And so how can we work together to strategically cultivate a system that rewards individuals for speaking up? And do we need to think about what is it within our system that is preventing individual learners to feel comfortable and confident to speak up? Power and hierarchy is always going to exist in the delivery of health care. And our students will have a place in that hierarchy. We need to think about how intensely we need them to know their place, and what exactly is that place? Is that place below us? Is that by our side as more an egalitarian set of structures to help us to raise them up, to be partners with us moving forward? If we don't think about this importance of a culture of respect within our environments, we are at risk of silencing our learners, pushing the concept of moral distress to the forefront as something that exists that we can't do anything about, rather than thinking about it as an area that we are able to tackle together. And so to build this cultural respect, we need to think about ways that we can really embrace our learners and all of us to speak up when we see things going on within our environment that is not promoting the respectful, inclusive environment that can be important to optimizing our learning climate. So what are some things that we might think about doing together to work on and aggressively work with individuals in our academic environments, both learners as well as faculty, to aggressively think about pushing and building a culture of respect? So as we have begun at my institution to really consider some of the areas that we see through a variety of different ways in which our students, our learners, and residents provide concerns about their learning climate. And when we sort of have been dissecting down on what are some of the factors at play, one area that we have been addressing is the issue of microaggressions and their impact on the medical education environment. And this is something that tackles back 3 of those different areas of those avenues through which we might be exploring ways to strengthen the learning climate. Microaggressions is something that many people have heard about, but I want to reinforce for you today sort of what are some of the key elements of a microaggression and why might it matter in medical education. So microaggressions are subtle. They are day-to-day put-downs that individuals might experience. They are very commonly directed towards marginalized groups, including women, and they may be verbal, they can be nonverbal, they may be environmental. They are ubiquitous in our environment. They are often unintentional, they are often unconscious, and they often go unacknowledged. But are these a problem in medical school? There's growing research to say that they are a problem in both undergraduate and graduate medical education. There was a study conducted at a medical school in the South where medical students were given the opportunity to learn a little bit about what a microaggression is, and then reflect upon, is that something that they had experienced in the course of their medical education. They had a pretty good response rate for this survey, and you'll see that over half of the learners at that medical school had experienced during their clerkship or during their medical education to date, they had experienced microaggression in their medical education. Significantly more women than men were experiencing microaggressions. Again, more commonly in our minority women and minority females. Interestingly, they were experienced fairly equally across both the second and third year of medical school. And you'll see that sexism and race, religion, color of skin, ethnicity were all of the areas around which those microaggressions occurred. And the way students were handling this included just blatant indifference. There's nothing that I can do about them. It just happens. Denial of their existence, and then some strong emotional feelings about its negative impact upon their medical education and their medical learning. Microaggressions are not only something that are experienced by medical students and residents in the academic environment, they're also being experienced by faculty. And the study I'll just convey to you was done across 4 institutions where faculty were given an opportunity to look at vignettes that had been derived by common potential microaggressions. They were shown these video vignettes in an interesting way. They were shown them because so often we don't see microaggressions. We just assume they're things that happen in our environment, but when they are brought to light and when they are described, these women faculty then, or all faculty, men and women, reflected upon their experience. And the women faculty in the study demonstrated that they had a significant percent who were experiencing these types of microaggressions as well. And I've given to you the themes of the most common areas that women were experiencing microaggressions. Again, sexism was one of the common themes, but things related to pregnancy and childcare, having their personal qualities underestimated, inappropriate comments, being relegated among mundane tasks, and then feeling excluded and marginalized were all areas around which faculty were experiencing microaggressions as well. So I just want to come back around to why do I think we should be caring about this? Well, microaggressions are an element that are going to negatively impact our ability to create a safe and respectful learning environment for all individuals, including our learners. And when individuals experience microaggressions, we know that those individuals tend to be at risk of disengagement from their academic and their professional work, higher degrees of dissatisfaction, concerns about personal safety, maybe some suggestions that higher rates of, when people experience higher rates of microaggression, that there's poorer mental health status and reductions in self-esteem. So those are some of the reasons why I think we need to really spend some time wrestling about this concept of microaggressions and their place in our work environment, and is there anything that we can think about doing to address these as a way, again, of thinking about a strategy to optimize our learning environment. So I talked a little bit earlier about power and hierarchy and the role that power plays in the hidden curriculum, and the importance of power in us to think about our role in partnering with each other and partnering with our learners to address some of these issues. But I also, as we think about microaggressions, want to bring up the concept of privilege, and something that we need to think about. I think all of us in this room have some degree of privilege by virtue of what brought us here, and I'm going to give you some questions to think about that in a moment. Privilege is something that we don't necessarily earn. Privilege is something that we have because of the opportunities that have existed in our lives. And privilege is something that adds to your power. It's your social capital. And it's germane to the conversation today because those with higher privilege are at higher risk for unconscious bias, and those with unconscious bias are at higher risk of committing microaggressions. And so if we want to think about establishing strategies to work on our microaggressions, we just need to understand our own privilege. We all have it in varying degrees. And those who are more at risk of being the victim of a microaggression may be in individual groups that have less privilege. And so we need to understand that differential. So I'm going to ask you to take a moment as I move to the next slide to ponder your own privilege using a series of questions. These questions are taken out of a book on the power of allies. We're going to get to the discussion about being an ally in just a moment. The book by Karen Caitlin actually provides a list of up to 50 questions that might help you to think about your power. But the way that she encourages us to think this lens of understanding our power is through a series of questions. So if you answer yes to things on this list, that just means that you have more potential, more privilege than others. And so, as I said when I mentioned earlier, I think that all of us in this room have privilege because there's probably not a single person in this room who can't answer yes to a few of these first few questions in terms of all of us in the room have a college degree. Many of us have attended elite universities. So again, privilege is something that we have. It's not something that we necessarily need to feel that we need to be judgmental about the fact that we have, that there are people around us who have privilege. We shouldn't be defensive about the fact that we have privilege. We need to understand that we do have privilege, and that privilege puts us at risk, all of us at risk, of having the bias and having the risk in and of ourselves of committing microaggressions. And so when we are able to have a better understanding of our own risk, we are better able to do some personal reflection on how much we are people who are potentially committing some of these acts, and to understand why those around us, the people that we work with, might be committing those acts, committing those microaggressions, and again, having a little bit of a better understanding of what we might do about them. So with privilege, let's go back to the concept of microaggressions and really just remind each other about what these are, what they sound like, for the purposes then of moving into the actions of what we might do. So microaggressions are often broken down into different types. Microassaults, things that are more purposeful and meant to harm, like I don't know why there are so many women in medical school. That would be considered more of a microassault. A micro-insult, these are more subtle snubs. They may or may not be intentional. It could be something like a white male saying to a prospective candidate of color, I believe that the most qualified person should get the job regardless of race. That might be a micro-insult. And then micro-invalidations. These are probably the most subtle ones. These occur most commonly in our environment. They negate or dismiss the experience or feelings of another, and sometimes they're environmental. So an example of a micro-invalidation could be an Asian American born or raised in the United States who was complimented for speaking good English or repeatedly asked where they're born. We have environmental microaggressions that exist. I work in the Department of Defense. We have lots of hallways with pictures. And as I walked down one recently through a command suite area, so a C-suite area, and saw a row of pictures of leadership individuals that were all white men. That's an environmental microaggression for some individuals. Lack of diversity in leadership groups, the lack of a gender-neutral locker room when we have transgendered individuals in a given location. Those are all examples of microaggressions that can occur in our environment that we need to begin to start thinking about and thinking about the messages that are being sent to individuals when they experience such a setting. So this image came out of Canada. They were working using some narrative as well as cartooning to sort of capture the experience of learners in our hidden curriculum. And I just encourage folks to look on this and reflect, is this something that you've observed or you've experienced? And how did that feel? Likewise, I want you to think about these. Have you observed or experienced being a female student, attending, resident, who has consistently been confused as being a nurse? Have you ever seen someone, a Latinx resident or a student, confused for housekeeping? Have you experienced that yourself? A student of color who's overlooked in rounds, a resident who has children excluded from a potential opportunity because of the expectation that they need to move on and get home for a personal responsibility. If you've observed these things, then you've been someone who's been observing microaggressions in your environment. Have you heard, I'm colorblind when I'm teaching, or you're just being sensitive, that's really not what someone meant, or again, how do you speak, sorry for my typo, English so well? Ironic, huh? So there are many, many more microaggressions, insults, assaults that we could talk about today. And I'm certain if I put you into paired conversations, you would have many others, and maybe many that are even more subtle than the ones that I chose to present for you today. So why do I care? So the primary impact is on the recipient of these microaggressions, and it can lead to imposter syndrome, ideas of self-doubt, whether or not that individual feels that they are deserving of what they are attempting to achieve in their environment when they repetitively receive these insults. There can be concerns about safety, issues of individuals may feel and experience regret. They can be demotivating and loss of productivity. And these are all those decline in empathy and burnout, increase in burnout that we are seeing in our learners. But the individual who is the victim of that microaggression is not the only person that's impacted by the activity, the event. There are also what we call the bystanders, other individuals, peers, patients, and team members who also may likewise have observed what went on, and what kind of conclusion are they going to draw from having observed that action? If they observe that and nothing is said, if no one speaks up, then the assumption is that that's a condoned behavior that may then be something acceptable and perpetuated in the environment. Again, those are the actions and activities that result in a culture that is not one that's cultivating respect. And when we have vulnerable learners, it's one that reduces their willingness to speak up and speak out, and it reinforces this concept of our hidden curriculum. So, what might we do? How might we choose to take action together when we see microaggressions occurring in our environment? Well, the individuals who are doing a lot of work in this area, and some work that we are doing on this, is to try and shift the idea of when you observe this, when you are a part of it, can you shift from being what we term a bystander to being an upstander? So what is an upstander? An upstander is someone who is able to recognize the wrong, and rather than staying silent and doing nothing, they actually act to try to actively make it right for the individual, for the environment. And doing that really takes courage. The courage to identify, address, and speak up is not a simple action. And there are many barriers that keep people from doing this, to keep people silent. Worries about your career, worries about your reputation, worries about how others are going to respond. What if I try to address the issue and I don't say the right thing? Am I going to change my relationship with my colleagues and my peers if I say something? And a sense that if I act, is it really going to make a difference? Those are barriers that are out there and they're known, but we've been silent for a long time on these issues. The silence on it has pushed my students to actually take charge of this, and we do a lot of, they've acted on it, and they want peer-to-peer work on this because they felt like the attendings around them weren't working on it. And so part of my initiative at my school is for students to be working on this from the ground up together and doing peer-to-peer work on how do you become an upstander in your environment. And I think that's important, and I'm glad that I have residents here today because I think you're an active piece of this conversation. But a way that we might begin to think about acting on this, now that we're thinking about it, we're starting to see it, we're starting to feel that we can be confident and courageous in doing something about this, is to see ourselves in the role of becoming an ally to the individual who is at the center of the microaggression. I'm going to use the term victim just because it makes it easier for me to talk about it, and we need to think about it in that way, the victim. How can we become an ally to that individual? Being an ally is especially powerful, particularly if you're in the majority group. So a male helping a female when the issue relates to sexism, a white physician working with an individual in a minority status, having individuals who have from the majority group who might have more power and privilege can be critical. An ally is someone who's there to help to shift the conversation, to amplify the person, the victim, to put them back into the spotlight of strength with a goal of achieving and understanding that I hear what's happening to you and I'm here to help you in that situation. The ally is there to help protect the recipient from the aggression, to stop it, to demonstrate support, to Be empathetic with what's going on. I've seen what's happening to you, and you don't deserve to be the focus of that behavior. And ultimately, the hope may be that allies can really help to foster an improved work environment. But I said it takes courage, and these are hard conversations to have. And so having some cognitive frameworks of how to address these issues can be very beneficial to all of us. And so one of the cognitive frameworks that we're working on training individuals on comes from bystander training for sexual assault. If any of you have heard the term green dot training, we use these it's in a variety of communities. We use this in the active duty population to try and teach individuals about how to act when they see something about to occur or something is happening that they want to intervene on with the area of sexual assault. But the D's associated with that can be very powerful. D is to directly intervene, to delegate, get someone to help you, to distract either party. The person who is committing the microaggression, the person who is the recipient of the microaggression, how can we get those two individuals separated and shift it from one another and move out of the moment and then begin to think about actions that we might take, such as asking clarifying questions about what is at the heart of that discussion. Really talking with individuals about what they just observed in a very factual manner. And engaging and exploring the impact of what just happened with an individual. Another way to think about it is to use the mnemonic open the front door. When you engage in a conversation with someone, an individual, about the microaggression, either the victim or the perpetrator, you want to think about observing, thinking, feeling, and desire. So that's the open the front door. What did I see? What do I believe? How do I interpret what just happened? How might the recipient be feeling in this circumstance? How might I help them? And what do I hope to achieve by having this conversation and moving forward in our environment together? And so some common phrases that one might think about using when you've observed a microaggression and you think about having dialogue with the victim and the perpetrator about this is, really help me understand what you meant by what they just said. Or I'd like to spend some time really understanding a little bit better what you meant by that statement. I wonder what other people who just observed what happened, how they might be reacting to that comment that you made. Or I really actually just don't understand what you just meant by your statement. Those are some common ways that you might think about phrasing your dialogue with individuals to engage a conversation that is respectful, but with the purpose of being an ally and helping to change our learning and climate to one that is one of greater respect, diversity, and inclusion. So to close, what do I hope that you will take from the comments that I've put together for you for the last 45 minutes is this. Our learning climate is really central to medical education. The hidden curriculum that exists, it's known. We must agree that it is present. It can be negative, but we have an opportunity to make it positive. And that hidden curriculum can be powerful, and I think if we learn to utilize it in an effective manner, it can strengthen our learning climates. We as medical educators, and those of you who will become future medical educators, are in positions of influence and power and privilege. We need to understand that. We need to think about how to effectively utilize that to strengthen our learning climate. And I hope you will have taken away from this conversation today that microaggressions are impacting our learning climates. And it's impacting both our faculty and our learners. But with courage, with recognition, we can think about addressing those microaggressions in our educational environments and become upstanders who have the courage to act and influence change for our medical education. And with that, I would be happy to take any questions from all of you.
to open it up for any questions.
Yes, ma'am.
Like somebody says, do you speak English very well? The key there is the intent. So if I want to give somebody a compliment that you speak really good English, like I say that sometimes a patient of mine who's Spanish speaking who says, I can't speak any English, and I say, actually, you speak pretty good English. So the intent may be more relevant, right? As opposed to, I've had many people tell me that, oh, you're from India and you speak really good English, how come? So you see the difference? I don't know, how can as a human being you do that? And sometimes perceptions are different. You may say something very well-meaning, but it can be perceived.
Absolutely, and I think you're bringing up the key element with a lot of this, which is the perception. And I think the worry is that you may assume what you said, what your intent was, but it may not be received in that manner. And so that has to be something that we need to be open to exploring with individuals about expressing why you might have said what you said, but being open to the idea that how it was received by someone may not have been as you have intended that. And to be willing to dialogue around that. But remember that someone, the way you say that, if they over and over again hear you speak good English, they may be interpreting that as, well, maybe I don't speak very good English and maybe I don't belong here. That why do you even need to bring it up to me? Why does that matter to my dialogue today? Yes, sir.
Having had that said to me, I've always wondered if the expectation is that I won't speak proper English.
That's exactly right.
Right. So
And then what does that say?
exactly.
If I don't
what
speak
kind of
that,
assumptions have you made about
are you saying that I don't have a quality education, that I come from someplace else that is less valued or less valuable, that I can't contribute to the environment in the way that I do? Are you saying something less about my capacity as a professional in this environment? I think that's a great example of the ripple effects. So we just have to be open and aware that that's a possibility. You know, people, you know, one microaggression, one small cut is less of an issue than individuals who may get this small cut after small cut after small cut, or another analogy is mosquito bite after mosquito bite after mosquito bite. If you have one mosquito bite from one microaggression, that's a minor nuisance. When you hear it over and over and over again, that's a little bit more detrimental to someone's overall sort of sense of self and well-being, leading to that moral distress and that discomfort that people will feel.
Any other questions? Well, okay, thank you for joining us. Thank you, Dr. Williams.